Good afternoon. My name is Susan Matheson. I'm presenting assignment number 3 for the Suicide Risk Assessment and Intervention course. We studied 4 concepts to suicide risk assessment and intervention. They are risk, coping, crisis, and chronicity. As you can see by the illustration, these concepts do not stand alone. They are strongly interlinked and dependent on one another, centering around the patient. Acknowledging this strong link allows someone to see the impact that each concept has on one another. For example, when you take the concept of coping, it cannot be viewed alone, because when a patient is ineffectively coping, it directly affects whether they're in crisis or not. It affects their level of suicide risk assessment, and it also affects their chronic state. If they're in the state of chronicity and they're a chronic risk, the ineffective coping could lead to a crisis, which could be the one change to change them to acute risk. So in order to view the patient holistically, we need to view their suicide risk assessment holistically also. So let's take the concept of risk. When we're looking at the concept of risk, what we're trying to do is decide the level of suicide risk of a particular client. In order to decide this risk, we need to weigh their risk factors for suicide against their protective factors. When we talk about risk factors, these include several different things such as suicidal ideation, hopelessness, if they've had past suicide attempts, functional impairment, if they're shut down, alcohol, substance abuse, and so much more. Some of these things, when we look at risk factors, are things that cannot be changed by the patient, such as a family history of suicide or if they're Aboriginal or a refugee. When we look at risk buffers, which are actually protective factors for the client, we look at things like, do they have a reason to live? Do they have hope? Social supports? Do they have the capacity to cope? Are they resilient? Do they have strong religion and faith? Internal or external strengths for managing risk? When we look at these things, we weigh the two against one another and we decide a level of suicide risk. Each agency who has clinicians that assess suicide risk assessment may have a different tool to do so. The one that we learned about in this course is called the Nova Scotia Tool for Suicide Risk Assessment. The important thing to take home about any tool that you're using in your clinical setting is that they are just tools. They're prompting agents to allow the clinician to explore into different areas to assess the suicide risk. It is not a numbers game, which means that just because there's a lot of tick boxes on your sheet does not mean that the client is going to be deemed high risk. It is simply for the clinician to investigate into that area and to do a thorough assessment. So therefore, you can have a sheet of paper that has several tick boxes ticked and still have somebody at low or moderate risk. Once you finish your interview with your client, you need to decide on what level of risk this client is at. As I said before, this is weighed against their protective factors and their risk factors. So you then need to deem the patient at either low, moderate, or high risk for suicide. Once you've deemed them at low, moderate, or high risk for suicide, the next step is to deem a risk management plan. And what this means is, where does the patient go next and what do we do? So is the patient going to be admitted as an inpatient? Are they going to be remaining an outpatient? And what interventions follow from there? Things to consider as an inpatient is, are they going to be on routine observation, close observation, which is Q15 minutes, or constant observation? As an outpatient, are we going to suggest regular follow-up? Are we going to suggest urgent follow-up? What type of supports are in their life and what type of safety plan can we put in place for this client to go home? Once you have your risk management decided on, the big step is to communicate this plan. Interdisciplinary collaboration, implementation, and effective documentation are absolutely vital in communicating this plan. When we look at documentation in particular, it is important to remember that the documentation in this suicide risk assessment is not just going to affect this one particular interview with the client. It can affect several suicide risk assessments. For example, 2 years from now, when the same patient returns to the emergency room and does not forego the same information that they get in this suicide risk assessment, the information can be pulled from the chart and has been effectively communicated as far as 2, 3, 4 years later. So document, 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 and do it effectively. It is absolutely vital. Now let's move on to coping. When we talk about coping, we usually think of ineffective and effective coping. But I want to take a step back for just 1 minute and let's talk about the things that affect a patient's coping on a higher level. What I'm talking about here is community action. When we talk about community action, we're talking about things like the population health model and how high-risk groups are actually identified and how prevention strategies are put in place to assist these high-risk groups. Derived from that are things like support groups to help with this prevention and to assist in the number of suicides that we have in our communities. When we talk about coping on a clinical level and what we can do as clinicians to assist patients in building good coping skills, we think of things like teaching. So teaching the client coping methods, reviewing with them coping methods that they've used in the past, helping them develop even new coping mechanisms. As clinicians, we need to foster things like resiliency and self-efficacy. We need to ensure that the patient has a safety plan and they know their contacts. They know how to deploy their coping mechanisms. In order to help foster coping in the patient, we need to collaborate. Sometimes that is with the family, sometimes that's with psychiatry, sometimes it's with therapists, and it's part of knowing our own role as clinicians and knowing when we are out of our scope of practice or out of our comfort zone. When we move on to talking in specific about effective and ineffective coping, when we look at effective coping, it is productive, it is helpful. We're dealing with the stressor, which means we are talking to family, we're using our coping methods effectively, we're doing things like attending support groups. And when you have effective coping, that links to having decreased numbers of crisis and decreased suicide risk or a stable suicide risk. When you look at ineffective coping, it's maladaptive. It's a quick fix or a cover. That's things like substance abuse, avoidance, self-isolating. When you have ineffective coping, that directly links to a possible increased number of crises and an increased level of suicide risk. Now let's move on to the concept of crisis. When people ineffectively cope with perceived life stressors, they're at increased risk for crisis. To decrease the risk of suicide, it is important for family members and client supports to recognize suicide warning signs. If they can remember simply, is path warm, then they've got it. We try to teach them to watch for suicidal ideation, substance use, purposelessness, anxiety. Is the patient trapped? Are they experiencing hopelessness or helplessness? Have they begun to withdraw from their family members? Are they more angry? Do they seem reckless? And has there been a dramatic mood change? Awareness of these warning signs will prompt family members to seek help for their loved one prior to the crisis and hopefully reduce the risk of suicide. As a clinician, one of the things that you'll be doing for the client who is in crisis is a complete and adequate suicide risk assessment. So we're back to the basics. We're weighing protective factors against risk factors and determining a level of risk. One of the tricky situations as clinicians that we can get into is balancing clients' rights versus client safety. It's important to remember that client safety is of the utmost importance, and sometimes things like involuntary psychiatric assessment may occur. As always, being diligent with documentation and effective communication is a must in these situations. If at any point you're uncertain what the next step is for a patient, it is important to collaborate with other clinicians, your supervisor, members of other disciplines, to ensure that client rights and client safety are ensured. As clinicians who assess patients in crisis, we need to prepare ourselves for different assessment settings. The setting may not always be the same. You may be assessing somebody in the emergency room, in an office, on the phone, and many more. Recognizing that the different assessment settings can impact your suicide risk assessment. It can impact the type of resources that you can draw from at that time and the type of collateral information that you may have access to. As for interventions for the client in crisis, it is important for the clinician to listen effectively. We need to find out what gives meaning and purpose to the client's life. We need to teach and reinforce coping methods, problem solving. We need to foster resiliency, have the client recognize that they have a reason to live. We need to get family involvement or other supports put in place, develop a safety plan, make the appropriate referrals, possibly to things like therapists, psychiatrists, support groups. It is important to recognize that effective coping methods can decrease the risk of crisis, and once the client is in crisis, we redraw back on those coping methods to diffuse the crisis in the immediate time frame. The final concept we're going to discuss today is chronicity. This refers to the client that due to illness or life circumstances remain at a chronic risk of suicide. That means that they're living with a suicide risk for a long period of time. And for many years, because they have several risk factors, they may never go below low or moderate risk of suicide. Often these clients have repeat visits to emergency rooms and various assessment settings, and as clinicians, it's very important for us to check our own attitudes. Reseeing the same patient for the same problem sometimes can be very tantalizing to a clinician, but it's important to remember that these patients can be at true risk for suicide, and a good suicide risk assessment is appropriate whenever the client presents to you. As clinicians, we collaborate with the client, the family, other disciplines, and we decide on what strategies will work best for this client. Sometimes it is long-term therapy, support groups. We do teaching, like things like safety plans. When we talk about coping in the chronic state, when people are effectively coping, they're at a chronic risk for suicide. These patients are always at either a low or a moderate risk. But when something changes with that patient, it's important to remember that even though they're at a chronic risk for suicide, and you may have assessed them several times in the emergency room, that change can actually lead to an acute risk for suicide and the patient can be in danger. Because it's important to remember that ineffective coping can lead to crisis, which can lead to increased risk for suicide. In conclusion, when assessing a patient for suicide risk, there are 4 concepts to consider: risk, coping, crisis, and chronicity. They don't stand alone, they're interdependent on one another, and in order to assess the patient holistically, we need to assess all 4 concepts of suicide risk and intervention holistically. After reviewing the final case study on Irina Belaska, interventions for Irina addressing the concept of coping are as follows: doing a complete suicide risk assessment, validating my clinical impression with Irina, communicating the level of risk that I find Irina to be at, questioning things like hospital admission, whether it will be voluntary or involuntary, interprofessional collaboration, possible substance abuse counseling, detox, psychiatrist to consider medication, diagnosis of depression, psychosis, therapist for things like post-traumatic stress disorder, adjustment disorder, teaching coping methods, fostering resiliency and self-efficacy with Irina, strengthening her supports, meeting with her family, developing a safety plan, giving emergency contacts, seeing if there's any community supports that help Irina, such things as support groups. It's important to remember that this is not Irina's first contact with the healthcare system, and there is a numerous amount of interventions that have been put in place in the past that did not work for Irina. So as her clinician, it's important for me to gather that information, assess why these did not work, and hopefully develop a plan that will work for Irina this time.